because they just said this themselves 2 years ago, and now they're saying it like it's some big surprise to them. But nonetheless, that's what they said. So they reaffirmed the opinion they published jointly with the American Society of Anesthesiologists. In the absence of a medical contraindication, maternal request is sufficient medical indication for pain relief in labor. Now, the problem with this is that they only are saying pain relief in labor. That doesn't necessarily mean epidural, because there are many other kinds of pain relief other than regional anesthesia. So it doesn't really tell you when it's acceptable to do an epidural anesthetic. Well, things really changed in 2005. This was, as they sometimes say, a game changer. This article came out in the New England Journal of Medicine, and it was the largest study ever published on this particular topic, and probably the best study as well. Randomized controlled trial, risk of cesarean delivery with neuraxial analgesia given early versus late in labor. 750 primogravid women randomized to an early or later anesthetic, the early being roughly around 2 centimeters, the later being roughly around 5 centimeters. And the way they did this was the early group was given a CSE at the first request for pain relief without regard to how many centimeters of dilation they were. The late group was given intramuscular or intravenous opioids, they used hydromorphone in this study, until a more advanced degree of cervical dilation. The result was that there was no difference in cesarean or operative delivery rates, and the labor was actually shorter by about 90 minutes in the group that received the early anesthetic. Now, I wrote the editorial that went along with this, and this is a brief excerpt from the conclusion of my editorial, and I'll just read through it for you. For those who experience severe pain in early labor and desire analgesia, the findings reported by Wong et al. Make it clear that safe, effective pain relief with the use of regional anesthetics should not be withheld simply because an arbitrary degree of cervical dilation has not yet been achieved. And this is the way we practice now. This is the way most obstetric anesthesiologists and obstetricians practice. Of course, not everybody is a believer, but this article was really the best and has really been followed up now by several other articles that have shown the same thing. So when this article first came out in 2005, there was extensive coverage in the media. There were stories on television shows and magazines and newspapers. The media really kind of focused on this particular study. And I was involved in some of this, some TV shows and some newspaper articles and things. And we have a very prominent show in the United States called The Today Show with Katie Couric, a famous news host. And they did a little segment on this when this article came out in the New England Journal of Medicine back in 2005. So I have the segment for you. I want to show you how this was portrayed in the American television media. It's about a 6-minute segment, and I hope that it will play here. This, let's see if we can get this going. So you can sit and listen to the television coverage of this. Let's see if that...
This is Today with Katie Couric and Matt Lauer, live from Studio 1A in Rockefeller Plaza.
Up next, labor pains, the new study about epidurals that could be a godsend for pregnant women everywhere.
740, for years, doctors have made women giving birth wait and wait and wait to get that pain-killing epidural. Now a new study in today's New England Journal of Medicine reports there's no need to hold off so long. Here's NBC's chief science correspondent, Robert Bazell.
The best way to treat labor pains, according to many experts, is an epidural, painkiller injected right next to the spine.
How bad was your pain? It almost totally blocks the pain impulses into the spinal cord and the brain. So really the woman feels very little of any contractions, and it has very little adverse effects on the mother and the baby.
You may feel it go in your back.
But until now, doctors have worried that for reasons not well understood, an epidural early in labor can increase the chances the child will need to be delivered by cesarean section. So women often have to endure hours of excruciating pain before they get the epidural.
Ouch!
But the new study from Dr. Cynthia Wong and her team at Northwestern Memorial Hospital should change that.
Kind of like your IV, it's going to be going in all the time.
The study found that when moms got complete pain relief, an epidural, early in labor, the babies were no more likely to need a cesarean delivery. And the mother's labor was an average of 90 minutes shorter.
Colleen Bradley got an epidural as soon as she went into labor yesterday. A few hours later, 6-pound, 4-ounce, Ileana Alexis was born after a pain-free birth. Dr. Wong says almost every woman can have it that way.
I don't think she needs to endure any more pain than she wants to endure.
For Today, Robert Bazell, NBC News, Chicago.
Yeah.
Cute baby. Dr. William Kamen is the director of obstetric anesthesia at Brigham and Women's Hospital in Boston. Dr. Kamen, good morning.
Good morning.
Nice to see you. So this is a study, one study, 750 women. Is this single study enough to change the way epidurals are administered?
Well, the study was larger than any of the other previous studies. You'll never convince everybody to change the way they practice anesthesia and obstetrics, but this is the largest study that's out there to date, and it's a very scientifically valid study because of the randomized nature of the patients.
Can you explain to us, Dr. Kamen, why doctors feared that an early epidural would result in more C-sections? Does it have to do with your ability to feel your muscles and to actually have a greater sense of pushing?
Yeah, it's a great question. There's a variety of reasons. One reason is that many of the epidurals that were administered many years ago, say 10 or 15 years ago, used much higher doses of the anesthetic drugs than we use today. And the ability to move the legs and to push the baby out was really hindered. Whereas today the drugs that are used have much less effect on the ability to move the legs and to push the baby out. In fact, many mothers can actually get up and walk around with the epidural anesthetic.
So now, in your view, will women be able to get an epidural as soon as they begin to feel pain? Because I think I was in labor for 24 hours, believe it or not, before I finally got an epidural, which ultimately resulted in a C-section anyway. But will you have to be dilated a certain amount?
Well, in this particular investigation, the patients were at 2 centimeters of cervical dilation. But basically the key is patient choice. Whenever she wants to get it, the results of this study would say that you don't have to wait until an arbitrary degree of cervical dilation to get the epidural.
And of course, women who want to avoid being in intense pain wonder, if you get an epidural earlier, does that mean it's going to wear off sooner? And you say no because actually you have an epidural needle.
I do. And I thank Dr. Balin, my colleague at Mount Sinai here in New York, for bringing these over. This is an epidural needle, and it's a relatively small needle. This goes into the patient's back. And the technique that was used in this particular study was a combined spinal epidural anesthetic, where this is a spinal needle, which is a very small needle, which goes through the epidural needle, and then a small injection is made right through the end of that needle into the spinal space. It really is.
I'm not a big fan of needles. So.
That's okay. It's a very small needle, and this needle
those
comes
amnio needles.
Similar
they freak me out. They're even longer, right?
They are longer. The amnio needles are longer. And then after the spinal injection is made, a thin plastic catheter, this is an epidural catheter, is placed through this needle, and this catheter remains in the patient's back.
Okay, and so it continues to administer the
It's
anesthesia.
given through a continuous infusion pump, so the medicine is continuously dripped in through the tube.
Are there some women medically or for health reasons who should not be given epidurals? Of course, there are ones who want to go through natural childbirth, and I really admire them.
Sure.
But what about for other health reasons?
For ones who don't want it, that's perfectly fine. But there are some rare health reasons why not to have an epidural. Most notably, problems with blood coagulation. People have some diseases that affect the ability of the blood to clot, and in some cases people who have had problems with their back, particularly surgery in their back, it may be difficult to insert the epidural.
And some other good news about this, an earlier epidural results in a shorter labor, which may mean less stress for the mom and baby?
Well, that was an interesting finding of the study by Dr. Wong and her colleagues, that the women who had the earlier epidural, actually it was a combined spinal epidural, had shorter labors compared to the ones who had narcotic injections in early labor. And it's not clear what the mechanism of that is, but it may be that the epidural early in labor allowed the mothers to relax, and the relaxation and decrease in anxiety allowed the labor to go faster.
Interesting. Dr. William Kamen, thanks so much for coming by this morning. Appreciate it.
Thank you very much.
And still ahead, a touching interview with the family of the late Christopher Reeve. That's right after this.
All right, well, there you go. That's an example of some of the media coverage. And unlike so much of the way obstetric anesthesia is portrayed in the media, which is often very negative, the coverage of this particular story was quite positive, and it was really a very good thing for obstetric anesthesia and anesthesiologists. Well, I showed you what some of the ACOG statements said in 2000 and 2002. Well, after this study came out, they issued yet another opinion, and this was in 2006. And what they said here was, since the last committee opinion on analgesia and cesarean delivery, additional studies have addressed the issue of analgesia and its association with cesarean delivery. 3 recent meta-analyses systematically and independently reviewed the previous literature, all concluded that epidural analgesia does not increase the rates of cesarean delivery. So ACOG is coming around on this. Furthermore, a randomized trial comparing epidurals done early versus later in labor demonstrated no difference in the incidence of cesarean delivery, and that's the study that we just talked about. Actually, let's skip that. So basically, ACOG has altered their opinions to take into account the new evidence. And as I said before, this is basically how we practice now. Once the patient is in active labor and committed to delivery, we will administer an epidural in most cases without regard to cervical dilation. Now, as I mentioned, other studies have come out on this since then. A very good study by OHEL. This was mentioned by Shilpa in her lecture yesterday. A very interesting study came out of China in 2009. And this is here. What's interesting about this is the size of the study. It was published in October 2009 in the journal Anesthesiology. And look at the number of patients, 12,700 patients in this. That was huge, huge. Imagine doing a randomized controlled trial where you enroll 12,000 patients. It's just incredible. But what they did was they randomized patients to either an early or a delayed epidural, similar to the previous studies that have been done. And I'll just get right to the conclusions, which is that epidural analgesia in the latent phase of labor, roughly cervical dilation of 1 centimeter, does not prolong the progression of labor or increase the rate of cesarean delivery. So again, the evidence is now quite clear on this, and I put this picture up. A friend of mine gave me this from a baby shower that they had where someone made this cake for them. All right. Well, let's move on to some other topics. We all have seen patients that when you're evaluating them for your pre-anesthetic evaluation, they say something like, I always need extra drug. They always need to give me more. Or sometimes they'll say, I'm very sensitive. Just give me a small dose. I only need a little. We've all seen patients like this, right? And we all think that maybe they're crazy, right? But maybe they're not crazy. And the thing is this. One of the emerging trends now in medicine, not just obstetric anesthesia, but all of medicine, is the concept of pharmacogenetics. And that maybe there are genetic polymorphisms that might affect the way we metabolize and respond to different drugs. This is just a very nice review article by Dr. Landau, a very recent review article about pharmacogenetic influences in obstetric anesthesia. Lots of research has been done on this, and I'm not going to talk about all the different issues. I'll just talk about one very specific one, which is that genetic variability of the mu opioid receptor may influence the response to intrathecal fentanyl in laboring women. And I'm not going to get into the details of what all these dots mean other than to say it's one of these MLAC studies looking at the median local anesthetic concentration or median anesthetic concentration required for effect. And what was found, again, without going into the details of the study, what was found was that a certain genetic polymorphism influenced the response of patients to intrathecal fentanyl during labor. So when these patients tell us that they're very sensitive or they may need more, then maybe there is something real going on. Maybe there is some pharmacogenetic influence, and we should always take these patients seriously when they say these kind of things. Now, antibiotics during cesarean delivery, we all give antibiotics. Traditionally, these were given after cord clamping. But latest guidelines, latest evidence supports giving them before skin incision, just like we do for any other surgical procedure. Just curious, by a show of hands, is everybody giving antibiotics prior to skin incision for cesarean section? Everybody? Anyone waiting until after cord clamping? Nobody. A few people. The evidence is quite clear on this. These are just a few of the articles. There are many others. Let's go back just for a second there. But it's actually quite clear now that that it's safe and has better efficacy to give these drugs, these antibiotics, prior to skin incision. So that's the way we practice. Rapid sequence induction. The classic teaching has always been that anyone who's pregnant requires a rapid sequence induction. This is what we're taught in our residencies. This is what we read in all the textbooks. But is it really, truly evidence-based, and is it always necessary that just because you're pregnant you need a rapid sequence induction? Well, it's interesting. If you go back almost 150 years ago, 1883, Joseph Lister, one of the founders of the specialty of surgery, also in antisepsis, so a surgeon, made this statement: while it is desirable that there should be no solid matter in the stomach when chloroform is administered, I assume no one here is giving chloroform anymore, but nonetheless, chloroform, it will be found very salutary to give a cup of tea or beef tea about 2 hours previously. Now, this is quite interesting because this was almost 150 years ago. And then we had almost a decade of absolutely strict NPO for 8 hours before surgery. And I remember in my residency, patients would get their cases canceled because they swallowed some water while they were brushing their teeth that morning. It was crazy. That's what we used to do. And now, the latest guidelines from both the American Society of Anesthesiologists and most of the other national societies are that we allow clear liquid intake right up until 2 hours prior to surgery. And it's interesting now that a surgeon said that 150 years ago. So maybe we can learn something from our surgeons. But with regard to pregnancy and rapid sequence induction, I would refer you to a very interesting recent article. And by the way, the theme of the lecture this morning is that I want to try to present some of the recent literature, things that have come out within the last 1, 2, or 3 years. So we're really up to date on the current concepts in obstetric anesthesia. This was in the May 2010 issue of Anesthesia and Analgesia. It's available online. In fact, I think articles more than 1 year old, you don't need a subscription to get the full text, so you can go to their website and get the full text. So this was a very nice review article on aspiration prophylaxis and rapid sequence induction for elective cesarean delivery, as they question time to reassess old dogma. And they go through a variety of points and discuss the evidence behind these various points. And what they conclude is that the evidence doesn't really support this. Now, what we're talking about is elective cesarean delivery. We're not talking about an emergency. We're not talking about somebody who just had lunch 1 hour ago. We're talking the elective case with an appropriate overnight fast other than clear liquids. Actually, let's just move on. Historically, the problem has been, years ago, patients having cesarean delivery, I'm talking many decades ago, often were done by mask general anesthesia without endotracheal intubation, often by inexperienced personnel. And of course, you can imagine the consequences that could arise there. Well, some of the things that we've always been taught, that the definition of a full stomach is this 2.5 pH and 25 ml volume. We could spend an entire hour talking about the evidence behind this, and the conclusion would be there's absolutely no evidence to support these numbers, meaning anything whatsoever that's relevant. The concept of gastric emptying has been re-examined in the last few years, and most of the current evidence supports that gastric emptying is normal in pregnancy. Does not decrease. Cricoid pressure, never been proven to be of any benefit. Proper technique has not really been defined, and in some cases may actually be detrimental. Excessive cricoid pressure can decrease the tone of the lower esophageal sphincter, and therefore may actually make things worse. So the conclusion being that the evidence does not support the concept that elective cesarean delivery under regional anesthesia, under general anesthesia requires a rapid sequence induction. I know what the classic teaching is and what our textbooks say, but we should all question the evidence as we evolve in our practices. Now, oral intake in labor. Again, it used to be that we would keep people strictly NPO during labor. It used to be that if you were really liberal, you'd let them suck on an ice chip once in a while. Well, now this has evolved. We allow clear liquid intake during labor. People are actually questioning whether some limited amounts of solid food should be allowed during labor. I know this sounds against every grain in our body of anesthesiologists to let people do this, but it's being questioned right now, just as so many of our things in practice are being questioned. An article from the Journal of the American Medical Association discussing whether women in labor can safely eat and drink. The American Society of Anesthesiologists has a set of practice guidelines for obstetric anesthesia, and here they support the use of clear liquids. They do say that solid food should be avoided in laboring patients, but again, this came out in 2007, so that's 4 years ago already, and since then there have been several articles questioning whether it truly is unsafe to allow modest amounts of solid food during labor. If you look at the latest guidelines from the European Society of Anesthesiology, while they also support clear liquid intake up to 2 hours before surgery, they also expand to mention gum chewing. And gum chewing is interesting because it seems there's quite a bit of evidence on this, and I presented some of this yesterday in one of my lectures, that gum chewing actually improves the recovery of bowel function after surgery. And it's a good thing. We should not only allow it, but we should actually encourage it. And this is what the European guidelines, they actually encourage clear liquid intake as well as gum chewing prior to surgery as well as during labor. So I'm going to conclude. I've got about 5 minutes to go. We all have heard of natural childbirth, right? Now, has anyone ever heard of the natural cesarean? So we all know that the cesarean delivery rates are roughly around between 30 and 40%. May vary a little bit depending on where you practice. So many of our patients are being delivered by cesarean delivery that an effort has been propagated to try to make this a more natural, better experience for the woman and her family. Now, this is just an article from a newspaper in the UK, the new natural cesarean. And you look at the headline there, with more babies being born by cesarean section, a new movement is campaigning to make the event a more natural experience. And this is all based on this one particular article, which comes from the British Journal of Obstetrics and Gynecology. This is from London. And what they talked about here was, as I mentioned, the natural cesarean. And they give a variety of things, suggestions, that can make this a better experience for the woman and her family. And some of these things are things that we as anesthesiologists can do. And this involves things such as early skin-to-skin contact, both with mother and father, and I'll show you some pictures of some of these things in a few moments. Slow delivery, so it kind of mimics the vaginal squeeze that you get with the vaginal delivery, allowing the mother to visualize the birth. You know, we usually have those big drapes up in a cesarean delivery, but you can lower those, let the mother watch the baby come out. Give the mother a free arm. Maybe put the oximeter on the foot or put the oximeter in the same arm as the intravenous and the blood pressure cuff. So everything's on one arm and you have one totally free arm to let the mother interact with the baby. Put the EKG leads on the back so the mother has a completely free chest, allowing early skin-to-skin contact, possibly even early breastfeeding, even in the operating. I'm curious, has anyone ever had the experience of allowing a mother to breastfeed in the operating room during a cesarean? I have. I see a few hands go up. So it's actually, if you get a nurse and an obstetrician that's into this, it can be a great experience, and it can be done safely and appropriately. So it's something that I think we're going to be seeing more. Certainly in my hospital, we're seeing more and more requests for this. Now, I don't know how well you can see these pictures. It'll be better with a video, but the point being a slow delivery as the baby emerges from the cesarean incision. Here you can see the baby being born without the drapes being up. The drapes are down. So the mother can actually watch the baby coming out. And then early skin-to-skin contact. So while the uterine incision is being sewn up, the mother has the baby on the chest. Now, we talk a lot about the mother, right? We really focus on the mother. But the father is involved as well. And there are various ways that certain cultures have embraced the father in the childbirth experience, and certain ways that we can embrace the father in the cesarean experience. I'm going to give a little historical background on one particular culture and how they involve the father in the childbirth process. Now, this comes from Mexico. This is a tribe in the northern part of Mexico called the Uchol Indians. And I'll read for you what is going on here. Among the Uchol Indians, the father traditionally sat above his laboring wife in the rafters of the hut with a rope tied around his testicles. When his partner felt a painful contraction, she would tug on the rope so that he too would experience the pain. You see, there's the poor guy up there. See, there she is. There's the ropes. So when she has a contraction, she pulls on the ropes. And therefore, the father can be involved in the childbirth experience. Now, I'm told that this tribe is now extinct, as you might imagine. But let's move on from that historical perspective to a more modern concept. And this is something which is brand new. This article, just from a couple years ago, in an American newspaper, paternal skin-to-skin contact offers cesarean baby same benefits, calming benefits as the mother. So even if you're not able to put the baby on the chest, which I understand has logistical obstacles during a cesarean section, you can do this with the father. And we have had a number of cases where they have requested the father have early skin-to-skin contact during the cesarean section. So I want to show you a few pictures from a case that I was involved with just a few months ago at my hospital. And here we have a baby born after cesarean delivery. The mother's on the operating table being sewn up, and there's the dad. He took off his shirt and was given the baby, and there he is cuddling up with the baby with a nice blanket. It was a beautiful experience. They actually had a doula with them. The doula came into the operating room with the mother and father, helped with the whole process, and it was just a great experience. And I would encourage you to try to embrace this. I think as anesthesiologists, we should be enablers. We should be the people who advocate for this. We should not be the ones that say no. we should be the ones to say, absolutely yes, I want early skin to skin. I want the dad to take his shirt off. I want the mother to breastfeed during cesarean section. I think that we really should be the facilitators for this and not the obstacle. Now, I'm going to conclude very quickly with something that we see a lot of: body art, piercings and tattoos. We see people all the time with various kinds of body art. Just showing, this is just a journal article from the Journal of the American Academy of Dermatology, showing the increase over the years in patients or in people with both piercings and tattoos. And you know, we see this all the time, all the time. The issue here for obstetric anesthesiologists is that some mothers are being told in various venues, such as childbirth classes, some of these pregnancy magazines, that if you have a tattoo on your lower back, that it would make an epidural risky. Now, that's not the case, but they're being told this, and many women are concerned that maybe an epidural could be dangerous if they have a tattoo. This is an article from the Wall Street Journal, of all places. Why some expectant moms are worried about tattoos. And they talk about this controversy of epidurals and lower back tattoos. Well, the fact is, with tattoos, it's a very popular site for body art, the lower back. The tattoos are all made of inert, organic and inorganic dyes. The key there is inert. These are not biologically active substances. They are not neurotoxins. They do not cause inflammation or irritation. And this was questioned and answered in the SOAP, Society for Obstetric Anesthesia and Perinatology newsletter a number of years ago. The opinion given by a physician who is an expert in forensic dermatology. How's that for a specialty? The amount of pigment that's used in the tattoo process is small. The pigments are fixed in the dermis and do not travel along a needle track. The pigments are made of inert metal salts, and the conclusion, there really is no danger at all inserting a needle through tattooed skin. So since we see this so commonly, I think that we can reassure our patients that if they have a big tattoo on their back, it is safe to give an epidural anesthetic. I'll show you a few pictures. This was from my own experience. This patient delivered at my hospital had one of the most appropriate tattoos that I've ever seen. On her lower back, it says, "Nobody's perfect." Okay, we all know that nobody's perfect, but if you look carefully, look below there, there's one, there's two, and there's 3 holes for the epidural. So truly, nobody is perfect. Now, we published a case report in the journal IJOA, International Journal of Obstetric Anesthesia. This was just a couple years ago, myself and one of my residents. We encountered a patient, she doesn't look all that big in this picture, but she wasn't really obese, but she was very edematous, had severe preeclampsia. You couldn't feel any landmarks at all on her back. She was going to have a spinal anesthetic for a cesarean delivery. Along the lines of what Warwick talked about in his previous lecture, severe preeclampsia, but we had no problems with spinal anesthesia. Minimal vasopressor requirements too. So anyway, she had this big butterfly on her back, and it was a beautiful design, nice blue colors, it was really nicely done, and it was very symmetrical. It was placed about 5 years earlier, and we assumed that since it was such a symmetrical design, that it would not look right if it was off to one side or the other. Therefore, the thorax of the butterfly, right over here, was used as a means to identify the midline. So we used, as you can see in the title of this case report, use of a lumbar tattoo to aid spinal anesthesia for cesarean delivery. And we used the thorax of the butterfly to identify the midline. The spinal went in on the first shot, despite the fact that we couldn't feel any landmarks because of her sacral edema, and everything was fine. So we published that in IJOA. And I think I'm going to just conclude there because we're running out of time. So I thank you for your attention. I hope I've introduced you to some of the current concepts in obstetric anesthesia. And